So my team at Vancouver, we have looked at the outcomes with Blinatumomab and Inotuzumab in patients with relapsed refractory BLL. We've chosen adult patients for this study, and what we tried to look at was to see the real-world outcomes and to compare it to already published literature, number one. And the second thing which we wanted to see was the correct sequencing of these agents to see whether we can comment on which order would be beneficial for the outcomes. So we had 51 patients for our study, and they were in the median age range of 42. They received primary chemotherapy, and some of them did not respond. They were refractory, or they continued to be MRD positive, went on to receive a second-line chemo. And then even beyond that, some of them continued to be MRD positive or refractory. So we ultimately, when we were using our immunotherapeutic agents, the primary cause of usage was relapse. Most of the patients got it for relapsed disease or else for MRD positivity, and few of them got it for persistent disease. And we found that the CR rate for Blinatumomab was approximately in the 70s, and for Inotuzumab it was in the 66%. And when comparing with the already published literature, studies by Kantarjian et al. Or Jabor et al., we found that this correlated. Some of the other findings that we got was, when pre-transplant setting, when Blinatumomab was used, the CR rate was higher than when it was used post-transplant. This was, however, the other way around for Inotuzumab. Again, with Blina, the relapse rate and the rate of progression was higher than Inotuzumab, and the time to relapse was lower than when Inotuzumab was used. We also found that, when we compared it to the already established studies, we found that the median overall survival, and that was lower in our study compared to the study by Jabor et al. And when we compared Inotuzumab in our study findings with that by Kantarjian et al., we found that the relapse-free survival was actually a bit longer than what was already reported. So the other thing which we wanted to look at was the sequencing. We had 8 patients in the cohort who received both the agents, and 6 of them, that is the majority, actually received Blina first, followed by Ino. And we found that Blinatumomab, when used as a first agent, had higher CR rate, versus when Inotuzumab was used as a second agent, they seemed to perform better. This was, comparable to a study by Woodikaran et al. From Memorial Sloan Kettering, where again Blinatumomab was used first, followed by Inotuzumab, and even their response rate was higher when Inotuzumab was used as a second agent. Even though our study number is quite low to actually comment whether this is sequencing, is the actual correct one, but even then we did seem to have some better outcomes. The other thing I wanted to comment from our study was that we found that, Blinatumomab CR rates, the performance seemed to be better than in Inotuzumab. It could be because Blinatumomab was used in majority of the patients and was used first, followed by Ino. But again, in a study conducted in 2019 and published in Advances of Therapeutics, where they have matched the Tower trial and Innovate trial patients, they found that the median overall survival was almost comparable. And there, Inotuzumab patients who received Inotuzumab continued to have higher CR rate, but that could be because the bias due to the number of prior lines of therapies used had not been removed. That's something the authors have said. So yeah, we do feel that, to summarize, we feel that our findings are kind of comparable to what is already there. We sort of found the same thing. And as for the sequencing, again, it seems like Blinatumomab followed by Inotuzumab would be a good combination, but 8 patients are very low. We do need more randomized matched trials to comment on the same.